Honorable guests, ladies and gentlemen, welcome to Unheard Stories. I am Lubna Hassaniya. Thank you all for being here. You make this event possible. I can promise all of you our story today will leave you completely amazed and deeply inspired. Some stories are very impactful that way. Experiencing them becomes immersive. As a child, I wanted nothing more than to sit in my grandmother's lap and ask her to tell me a story. From her lap, I sailed the skies on Aladdin's magic carpet. I ventured into Ali Baba's cave. I also got to experience that unmistakable fear she had to live through as the great famine of World War I swept through Mount Lebanon, decimating half of its population. Her stories were as unique as she was. They opened up my imagination and broadened my world. From her lap, I could see a glimpse of the past, of my ancestors' strife and their tenacious love of life. Although many aspects of our lives are imposed upon us at birth and ideologies indoctrinated in us at an early age, we remain empowered with a mind that is capable of formulating everything and anything. We can hear stories, analyze them, process them emotionally, and finally draw our own conclusions. Now, regardless of how limiting our environment is, our choices are infinite. They are as endless as our minds are free to roam and ponder, free to imagine and create. The greatness of the human mind should never be undermined. It grants us the greatest power, the freedom to be authentically the individual we want to be. It grants us the genius, Einstein and Descartes, Nikola Tesla and Gibran, Pythagoras and Rumi. You are born with wings, Rumi told us. Why prefer to crawl through life? He asked. Well, my guest today has been grooming his feathers for quite some time, and his story is one of many triumphs and breakthroughs. He's been called the miracle doctor, the giver of the gift of life. But while his wings have carried him very high, his feet remain anchored on the ground. The first time ever I saw Dr. Chmait was many, many years ago, and it was on ABC News. I jumped of joy hearing him introducing fetal surgery to the world and his efforts to save unborn babies from death. Little did I know that a few weeks later, I would run into him and his beautiful wife, Johanna, at a gala dinner in Los Angeles. I walked up to you, Dr. Chmait, and I said, I saw you in the news. I am so proud of you. And today, I could not be any prouder. Thank you for accepting my invitation to be our guest on Unheard Stories. Dr. Chmait.
Thank you, Dr. Hassani, for inviting me. It's quite an honor to talk to you and to have this panel listening to us this morning.
Yes, welcome. The honor is all mine. You are recognized as an international leader in minimally invasive fetal surgery, Dr. Chmait, and that's absolutely brilliant. Tell us a little bit about your professional journey that led you to earn such a distinguished recognition.
Well, I was born in Southern California and raised in Southern California in Los Angeles. My parents are both Lebanese and they were born abroad. I went to medical school at UCLA and did my residency in OBGYN and my subspecialty in maternal fetal medicine. It's called MFM or perinatology. And the role of an MFM is to take care of high-risk pregnancies. So these are mothers who are, they themselves are sick for one reason or another, or the pregnancy is complicated for one reason or another. Mm-hmm. And one of the ways their pregnancy can be complicated is if their baby has a problem, an anomaly, or is sick. And as an MFM, our role is to diagnose this problem. But 20 years ago, when I was in my fellowship at UC San Diego, there was very little we could offer. All we could do is diagnose. We had high resolution ultrasound, so we could identify and find these problems, but there wasn't very much we could do about it. It was a little frustrating as a physician to be able to see a problem but not do anything about it. And that left the mother with very few options. And it was this issue that led me down this road to fetal surgery.
Yeah, yeah. Well, your professional journey is intense, I'm sure, and it requires tons of patience and perseverance to get to where you are today. Well, we all know how devastating it is for expectant parents to learn that their eagerly awaited baby has a life-threatening condition. In
Mhm.
historical terms, how did the concept of the fetus as a patient start to materialize, and how did it eventually develop into the fetus becoming a candidate for surgical intervention?
That's a very good question because historically, um, people didn't even recognize a baby after they were born for several days or even weeks because the survival rates were so low.
Mhm.
Um, not that long ago, several generations ago, really the focus was on the mother,
Yes.
and the maternal mortality rate was relatively high. And if you think about all those stories that you read about when you were younger, many of them have to do with orphans.
Mm.
And the reason is because the maternal mortality rate was so high.
Mm.
Um, orphanage, orphans was what was a problem, and it was a blessing for the mother to make it through the pregnancy. But as things improved, as we learned about the germ theory and developed antibiotics and improvement in anesthesia,
Yeah.
and and blood transfusions became available, and being able to do a cesarean section for obstructed labor, um,
Mhm.
those kinds of things. As the technology continued to improve,
Mhm.
particularly in the latter half of the 1900s, then we can start focusing on the baby. And then high resolution ultrasound came along. So um, before the 80s, um, a mother, it would not be unheard of for a mother to deliver a baby and the doctor to then walk out of the room and the nurse to call back the doctor saying, "Excuse me, doctor, there's another baby coming out."
Yeah.
They didn't even know they had twins. So then we were able to take care of the mother, and then we can divert some of the focus to help trying to optimize the outcome for the babies. And as neonatology improved as a field, these are the doctors who take care of premature babies. Um, as that field began to grow and mature, we started to be able to then think about how to take care of the baby. Don't forget, in the 1960s, right? In 1963, Jacqueline Kennedy delivered a baby 3 months prior to the assassination of her husband. We forget about that. And that baby was born at 32 weeks gestation, but died of complications of prematurity, respiratory distress syndrome, RDS. Nowadays, a 32-week baby has well over 90% chance of survival. So as the technology improved for mothers
Mm.
and for babies, then the window started to grow for the opportunity to be able to take care of fetuses. And in the latter half of 1990s, ultrasounds became very good, and genetic studies became improved, and we can now understand the natural history of disease. And when you understand the natural history of disease, you can find points within there to potentially alter the natural history to improve outcomes. And basically, all that came to a head in the late 1990s, early 2000s. And that's really where fetal surgery took off.
Well, the way surgery in general and fetal surgery in particular have evolved over the past 100 years for general surgery, it's absolutely astounding. I mean, for one thing, think of anesthesia, right? It
Mhm.
was poorly understood. It wasn't until recently, however, when the first successful fetal surgery was conducted. Since then, it has evolved tremendously. Could you briefly walk us through the evolution of fetal surgery from what you call the exit procedure, to the mid-gestation open fetal surgery, and then to the minimally invasive surgery you pioneered today?
Sure. So, fetal surgery in one form or another actually started in the 80s, 1980s. It was very not definitely not as sophisticated as it is now, and it was done doing open techniques. It's called open maternal fetal surgery, and what that means is that the mother is under deep general anesthesia, not regular anesthesia. It has to be very deep anesthesia to keep the uterus relaxed because the uterus wants to contract. And then the surgeons do a laparotomy. That means that's an incision on the abdomen, and they exteriorize the uterus. And then they do a hysterotomy. It's an incision on the uterus, the same incision you do for a C-section, but instead they'll just exteriorize the baby, and then using their hands, they'll do a surgical intervention. And that was beginning in the 80s and 90s, but it really wasn't until 2000s where things started to take off. The problem with open maternal fetal surgery is that obviously there are two patients here, right? There is the mother and the fetus. And one of the first tenets of being a physician is to do no harm. And there's significant risks to the mother on using the open technique because there's an anesthesia risk. The risk is the anesthesia risk is not, this is not normal anesthesia. This anesthesia is very deep. Sometimes it's even hard to wake the mothers up after the surgery. They may have to spend a night in the ICU. That's the kind of anesthesia they're given. Also, that hysterotomy, that scar that's done on the uterine wall, unlike a regular C-section, when you do a regular C-section, you take the baby out and then you close the uterus. But here, when you do fetal surgery in the mid-gestation, you have to reapproximate the uterus after your surgery and suture that. But that incision is under constant tension over the course of the pregnancy as the uterus, of course, is expanding to accommodate the enlarging fetus. So that scar is under tension, and there's a significant risk of uterine rupture or dehiscence during the index pregnancy as well as future pregnancies. So there's a legacy to open maternal fetal surgery in that even after that pregnancy is over, the next pregnancy has at least a 10% risk of spontaneous uterine rupture where the uterus opens up, explodes, and it can lead to severe bleeding and 40% risk of fetal demise. And it's very unpredictable. It can happen in the middle of the pregnancy spontaneously. So because of those risks and our goal to decrease the risks to the mother, but yet still provide the benefit to the fetuses, that's where the minimally invasive fetal surgery came in. And that's my area of expertise. And that's pretty much the kind of fetal surgeries that we do here in Los Angeles. So our surgery that we do is minimally invasive. So it's all done through tiny little ports that each of them are a fraction of a centimeter long. And they are placed through percutaneously through the maternal abdomen and into the womb. And then there's a scope attached to it with the surgical instruments. And we're basically looking at a monitor, and we're able to do the surgery while the baby's still inside the womb. And by doing it this way, it decreases the maternal risks. So the risk of anesthesia is less. The risk of injury to the mother is much less. There's no uterine legacy. So the patient can have a normal delivery for that index pregnancy and for future pregnancy. She doesn't have to have a C-section.
Amazing. Yeah.
And the risk of uterine rupture is negligible. So now that we're able to access the uterus minimally invasively, then the risk-benefit ratio totally changes, right? And we can offer these interventions to the baby with minimal risk to the mother.
Yeah, that's amazing. It's really admirable what science and medicine have accomplished through the years, Dr. Chmait, with the greatest human minds behind them, a mind like yours. What are some fetal conditions you've treated through the years? And statistically speaking, how did fetal intervention affect postnatal morbidity?
Okay. So my journey, so as you mentioned earlier, started because of a condition called twin transfusion syndrome, or TTTS. It's a condition that affects identical twins. These identical twins share the same placenta. That the placenta is the organ that's attached to the womb that gives the babies oxygen and nutrients. Some kind of identical twins share the same placenta. And because they share the same placenta, they have these vascular communications, these links that connects the circulatory systems of the twins together, so that when both hearts are beating, blood can cross over from one baby through the placenta to the other one and back and forth. Another way of looking at it is, if you're able to imagine one little red blood cell, at one moment in time, it could be inside one baby, and the next moment it can go down the cord, cross over the placenta to the other baby. So it goes back and forth. In 10% of these kinds of twins, there's unequal sharing of blood, where one baby starts losing blood to the other one. And that condition is called twin transfusion syndrome, or TTTS. And without treatment, there is a 95% chance of losing the pregnancy. It's a very serious condition. And because the consequence is so severe, that was one of the very first conditions that people started to focus on in fetal surgery. This is back in early days, and this is back when many people didn't believe that this is curable.
Yeah.
And that's how I stumbled into this whole arena of fetal surgery. It really was a matter of, I wouldn't say I consciously was able to know that this is the road that's going to lead me to this destination. Anybody who's watching who thinks that you can plan like that, that's not true. All you can do is set yourself up for the opportunity. And that's what happened with me. Um, and I hope if there's young people listening, they'll understand that point, that my journey happened not because I knew that this condition was amenable to fetal surgery, because many of my advisors when I was at UC San Diego were following the textbook rules, laws that were written in the textbook, like as if it was on concrete, that this is not possible to treat. You cannot treat, I'm not going to go into the medical details, but basically you cannot treat this. But there was one doctor who was a pathologist who was in the basement of that hospital, who I was able to talk to. And he told me, he's like, don't listen to those guys up there. You look at the placenta. Come here. Look at this. And I remember it was during an Easter break. I was on vacation and I was in the basement with him looking at these things. And I realized that, yes, this is possible. And I'm not going to listen to the people who are telling me it's not possible. And that's how I ended up going to Florida and working with the pioneer in this condition. And his name is Ruben Quintero. And the condition, the staging system, is named after him now, 20 years later. It's called the Quintero staging system. And I happened to find him. And I happened to have a very loving wife who was willing to move my family and 3 little boys to Florida, where I was able to learn fetal surgery with the guy who pioneered the minimally invasive approach. And that's how I ended up going down that road. And when I moved back to Los Angeles in 2005, late 2005, and brought that expertise with me. And I came to Los Angeles back when minimally invasive surgery like this was still very rare. In the western half of the country, there were only 3 centers that were doing fetal surgery, but not the way we were doing it. And that's just kind of how I was able to kind of start down that road. And what we do for that condition is we place a scope into the womb and we identify all those connections on the placenta and we laser occlude them, separating the babies from each other. So they're not sharing any more blood. And after laser surgery, we cure this condition 100%, and it improves the survival rate So after laser, there's an over 90% chance at least one baby will survive, and over 70% chance both will survive. So it really flips the perinatal outcomes from a 95% chance of demise to over 90% chance at least one baby will survive.
Yeah, that's amazing. That's amazing. And you've done thousands of these surgeries, right? And even
Yes,
with the most complicated and delicate ones, you've successfully done them and conducted them using your minimally invasive endoscopic approach. Um,
correct.
but the surgery of one particular defect, spina bifida,
Mhm,
where the spinal cord is and the fetus is open and leaking fluid,
mhm.
had long bothered you because it was still requiring a more invasive approach up till recently. Now, one of your many success stories revolves around spina bifida. Can you share that story with us? The story of Gilda.
Okay,
What brought her to you in the first place, and why was she a special case, not only to you but also to history books?
okay. So you're right. Open spina bifida is a condition that affects babies, fetuses. The neural tube. Any young budding doctors will have taken embryology and remember that the neural tube starts flat and closes, and the back ends up closing like a zipper. And sometimes that zipper, as the zipper is going down the back, it gets stuck and the spinal cord stays open. And if the spinal cord stays open, the spinal cord is basically exposed to the amniotic fluid, and the cerebral spinal fluid, the CSF, starts leaking out. And what doctors realized 20 years ago was that these babies, these fetuses, still were moving their legs during the pregnancy. And this is where I was explaining to you that ultrasound allowed us to understand the natural history of disease. So you could see the feet were moving. But as the pregnancy continued, particularly in the third trimester, the babies became progressively paralyzed. So when the babies were born, they couldn't move their lower extremities. And so people started doing sheep surgeries, sheep research, and then started doing open maternal fetal surgery where they would close the back. And by closing the back, you will protect those nerves from the caustic amniotic fluid, which would cause injury to the nerves. And also by sealing the back, there was no more CSF leak. And the neuroanatomy is not distorted. It actually can normalize in utero, allowing for the normal CSF flow and can improve the neurological outcomes in the brain and prevent the need for these babies to need a shunt in the brain, which is a big issue. So a large study was published in 2011 called the MOMS trial in the New England Journal of Medicine that showed that if you do the in utero repair, it will double the ability for these kids to walk and decrease by half the need for these kids to have this hardware in their brain, which they will need for the rest of their lives. And this hardware, this VP shunt, can get blocked, can get malfunction, infections. Some individuals will need hundreds of surgeries over the course of their lives to keep this device working. If you don't need hardware in your brain, you'll have a much better quality of life. And so the MOMS trial showed that prenatal repair improved the outcomes of these kids, but the cost of that prenatal repair is the fact that the mothers had to undergo this open maternal fetal surgery, which had significant morbidity for the mother for the pregnancy. They had to have a C-section for that pregnancy and all future pregnancies, and there's a risk of uterine rupture. So the question is, can we do the same prenatal repair, but minimally invasively? And that's my area of expertise. And the journey to get to Gilda, the reason why that's so special was because that journey started over 10 years ago. And I was working with some collaborators in Brazil. Why Brazil? Well, because to do sheep surgery in the United States is very prohibitively expensive, and you need to have lots of money and grants. And so we collaborated with some doctors in Brazil to bring our technology and our expertise that we have with minimally invasive surgery and working with them with their animal model and to basically perfect the ability to do the same surgery, but rather than using your hands, we can do it all minimally invasively. And we finally were able to publish some animal work. Then we come to the United States again. I went back and forth to Brazil many times.
Yeah.
Again, thanking my wife for allowing me to take those trips. And then we submitted a protocol to the FDA, and that process was painful, but we finally got approval. We got FDA approval to do our first human patient. And our first human patient happened to be Gilda, now 2 years ago. And she understood the risks, but wanted to have the benefit of this repair for the baby, but minimal risk to her. And so we were able to successfully do that first case about 2 years ago and successfully close that baby's back. And the mother delivered at term and had a normal vaginal delivery. And that baby is doing great, does not have a shunt, and is moving the toes and stuff. So since then, we have done many more surgeries. We did one this week, and we have 2 more next week. So we've kind of really taken something that was just an experimental model 10 years ago, and we're able to transition to doing it in humans. And we're the only center in the western half of the country that offers percutaneous physioscopic spinal bifida repair, and have done the most of any center in Northern America.
That's nice. And that's at USC, right?
Yes, I work at USC.
Well, it's always uplifting to hear stories with happy endings. And it must be fulfilling to you, Dr. Chmait, knowing you've made a difference in someone's life. Now, there are also situations, they're rare situations, where the fetus demonstrates complete heart block, which usually results in the death of the fetus or the newborn baby. Can you tell us a little bit about your efforts to resolve that problem? And if you can also talk about the 2 patents you hold for fetal pacemaker, please.
Yes. So congenital heart block is another condition that can affect human fetuses. And heart block means that the electrical impulse that goes down the heart is not able to do so correctly. And the baby develops what we call bradycardia, or a low heart rate. And if a fetal heart rate gets too low, the baby goes into heart failure. And a fetus that's in heart failure develops high drops, becomes very swollen. There's edema, there's water around the lungs, water around the heart, water around the belly, and they can suffer a demise. The sad part about it is that if we're able to get the baby to term and get a pacemaker into the baby after birth, the baby can have a completely normal life. And there are people who live with a pacemaker and have a very normal life. But we're helpless to do anything to a fetus, that especially if a fetus is hydropic, because we can't deliver early, because a hydropic fetus that's premature has very poor survival rates, particularly if less than 32 weeks gestation. So we also try to think of a way to help these babies. And with some collaborators, and that's a common theme that everybody should know, that it's not like a Marvel movie where one superhero comes and fixes everything. These are all teamwork with lots of people involved. But in the case of this fetal pacemaker, we worked with some bioengineers at USC in the engineering department and explained to them our dilemma and the form factor required to place a pacemaker into a human fetus. And they said, what? You want us to make a pacemaker? What size do you want that? But the technology is there. And they were able to do it with graduate students. They were able to devise a pacemaker that could be used using the surgical equipment that we normally use. For example, the same instruments that we use for twin-twin transfusion syndrome, the same cannula, the same trocar, but now the pacemaker looks like a tiny little pill that we could use through that trocar that we can introduce into the baby. And the pacemaker was developed, prototypes were made. We did get an NIH grant, an R01 grant to devise these pacemakers and to use an animal model to show that it's possible. We started off with small animals first, and then to the sheep model. And there was a lot of technology that the engineers had to work out. Like for example, the battery. Because the form factor was so small, they wanted to have a battery that could last for the gestation that we needed it to for the entire gestation. So they devised a rechargeable battery, and you recharge it externally with like this big hula hoop that would be placed on the maternal's abdomen once a week to recharge the battery. And yes, we did get these patents, and we have the IP, and we did get stuck though. I could not, even though we got what's so-called a humanitarian use designation from the FDA. And when you get a humanitarian use designation, the regulatory hurdles drop down tremendously, because without treatment, these kids are going to die. So we got the HUD, but we could not use a prototype from a lab that postgraduates put together. That's not how it works. We had to have a company fabricate that. And that's kind of where we kind of got stuck, because which company is going to want to produce a prototype that's going to help a fetus? The medical legal aspects can be a big hurdle. They need to focus their efforts on bigger projects. So we kind of are stuck here, but I am not, I'm optimistic that this chapter is not over yet. Even though we have the prototype, we have the IP, but the technology is there, and the form factor is improving. And I think that it's going to converge where a company is going to be producing a pacemaker for other reasons, but will be useful for us. And we'll already be in position to provide this treatment. But as of right now, we have not offered this treatment to any human fetuses.
Well, that's all remarkable work. Good luck with the patents. Hopefully, sometimes. Now, it must be exciting to be invited, not only once, multiple times, to share the story of your amazing success on news outlets and TV shows. But the excitement reaches a whole new level when you're asked to serve as a consultant for the shows ER and Grey's Anatomy. Can you tell us about that?
Yes. So it's actually kind of interesting, the background regarding this. So if you think about the common American, or doesn't matter what country you're in, many individuals get their medical information from TV shows. And that's something that the CDC figured out. They're like, wait a second, we're trying to educate the population about stuff, but Hollywood is producing all these shows. So it was actually USC who they developed this office, and they got a grant from the CDC to be able to offer to Hollywood this one telephone number. So as you know, I work in Los Angeles, and all the movie studios are a stone throws away from USC. And so what they did was they gave this number out to all the studios so that they could, if they're doing a show that has a certain topic, they can call that number and somebody will route them to a physician specialist in that area within USC. So that's the background. And I think that's kind of interesting. So some of these shows that you watch, even though sometimes we roll our eyes like please don't do that. That's not gonna be good. But we're there to help guide some of these shows. And there were a couple instances, for example, in the TV show ER, there was a pregnant woman that got in a car accident, and there was a significant, for the purposes of this show, there was a significant fetal to maternal hemorrhage where the baby bled into the mom. And they, through this service, they called me and invited me to the set. I got to sit down in one of those chairs and next to the director. And basically, they wanted me to tell them how to do a fetal blood transfusion. And that's something that I do routinely. And this is where you put a needle into the baby's umbilical cord to give the baby blood. And we need to do that for several reasons. There's several conditions in which the fetus becomes anemic. And we have to do a so-called fetal blood transfusion. So they had me come and sit there and help them out. Interestingly, I gave them my video. So I took my former patient and we took out the patient's name. And that was the video that you could see in the TV show. And I just was there as a consultant to help them do it right. In regards to Grey's Anatomy, that was more of several seasons worth because they actually had a fetal surgeon on that show. I'm embarrassed to say I've never watched Grey's Anatomy. I don't even know who the surgeon was, but they had a fetal surgeon on that show. And so they would invite me to the writer's room every season. It just so happened the studio was not too far away from my work. And I would be there for a couple hours as they run through the shows for that season. And I would kind of nudge them one way or the other. And the point was to try to get them to be as accurate as possible. And they'll try to say, can we do this? And I'm like, no, cannot do that. Please don't do that. You can maybe do this. And I'll try to have them add a few words as cautionary, like, do you mind just saying this to inform people that this condition is associated with this and to avoid this, or, just to help out as a public service, basically. And then every other week they'll call me, and on the drive home, I will answer some questions for the writers.
I hope they're not a nuisance. I hope they add some fun to your career. In addition to your groundbreaking fetal surgery you performed, Dr. Chmait, you also direct a research program at USC. And with the research program, you study fetal disease, of course, and investigate potential treatments. You are also associate professor of obstetrics and gynecology, as well as pediatrics and surgery. Which role describes you best? Are you the patient explorer doing research, or the teacher and the mentor? Or are you mainly the problem solver doing surgery?
That's a good question. I think that we all kind of wear several hats. If I had to pick the one thing that I identify with, I think is as an individual physician taking care of the patient in front of me. And they basically are coming from far away for my surgical expertise. And it's a big, just imagine a mother, sometimes they're told that they have this condition, the fetus has this condition, and within 24 hours, they're at my office because it's life-threatening. A third of these patients are from outside of California. So they literally, within 24 hours, have to get a ticket. They have to fix their home situation, get a babysitter, whatever, get in an airplane, come over. And within 24 hours, they're seeing me. It's a blur. And to be able to try to explain the situation, let them understand the gravity of the situation, but let them know that there is some hope. And within 72 hours, the surgery is done. They get discharged from the hospital the day after surgery, and they're back on an airplane on their way home. It's like surreal. And to be able to offer these patients hope, to be able to hopefully improve the outcomes for these kids, I would say that's what I identify with the most. And to be able to do that, we need to do our research to advance the field, mentor fellows and residents, and one of my greatest joys is to see these young doctors to be, go through and become doctors, and many of them, I can see some of them are even on this call, are now successful physicians out there, paying it forward to their patients. So, but I would say my number one joy, or what I identify with, is taking care of that one patient in front of me, one patient at a time.
That's nice. Yes. And as a surgeon, you have to be able to differentiate between what to do and what not to do, because many lives depend on your decision. And you also have to pay attention to details, definitely respect time, and like you said, loving to help others. And last but not least, you have to have a good and solid foundation of work ethic. And how much did your background and the core values of your parents or your parents instilled in you prepare you for the rigors of your surgical career and make you the person you are today?
Well, I think that, like many people on this phone call, my parents, my dad is born in Lebanon. My mom was born in Brazil, but was Lebanese and moved to Lebanon when she was young. So they immigrated to the United States. And so I was born in the United States, in Southern California, but my parents were basically, raising me to understand the importance of education, and that was the number one goal. And I've tried to pay that forward to my children as well. We acknowledge the fact that education is something that nobody can ever take away from you. They can take away your money, they can take away everything, but they can never take away your education. And that was instilled upon me at a very early age. And I've tried to instill that to my kids as well. The importance of being able to offer your family and your community the best opportunities through your education, I think, is the biggest gift that my parents gave me and that I hope to give to my kids.
That's excellent. Thank you for sharing that. Now, you grew up in LA, you told us already, in beautiful Southern California. That was the mid 80s for you. How was it back then? And how well were you able to connect with your Lebanese American identity and your heritage?
So yeah, I was born in 1971. I was raised in Los Angeles. So basically, the war in Lebanon was raging during my childhood. My dad worked for an aerospace engineer. He's an aerospace engineer. He worked in Los Angeles, so he couldn't even get clearance to go to Lebanon because he worked in classified stuff. So we really were marooned in the United States as the war raged in Lebanon. But I remember, particularly in the early 80s, when the U.S. Marines, as you know, in Lebanon, they had the tragedy for the U.S. Marines. Many Americans were killed. And I was a young kid. I think I was like 12, 13 years old. So being Lebanese wasn't very popular when I was a kid. It was actually kind of difficult to kind of negotiate through that during my high school career. I think that's changed now. That's now history, but at the time that was a little difficult.
There's so much richness and diversity. I
Mhm.
always say a variety of perspectives can only lead us to more creativity and growth. Can we go back in time a little bit? 1992. It was a
Okay.
turning point in your life. And it all started when you took a trip to Lebanon.
Yeah.
First, what took you to Lebanon that year and what happened there?
So that was the year that I basically made it to a medical school. And so I just wanted to go on vacation.
Mhm.
So I spent the summer in Lebanon
Mhm.
and stayed with my grandparents by myself. My parents weren't with me.
Mhm.
And I met my wife, Johanna.
Mhm.
And I remember calling my parents and telling them, I think I met somebody kind of interesting. And they were like, what? Uh, don't do it. Like, be careful.
Early.
We don't, because I went there by myself with no intention of getting engaged
Yes.
or anything like that. But I met Johanna, and she's
Wonderful.
the wonderful person in my life. And and I obviously it's been a wonderful a union, and
Yes.
got married a year after.
Mhm. Yeah, you have a lovely family, Dr.
Yeah,
Chmait, and
thank you.
your three boys, now young men, are all
Yeah,
well set, each on his own path of success.
thank you.
What's next for you? Where do you see yourself going from here?
So we're still so the spine bifida surgery is our newest thing,
Mm-hmm.
and it still needs to be optimized.
Mm-hmm.
So we're have surgical challenges that need to be overcome, and we are getting better and better. When we first started, we had to do the surgery through 4 ports.
Yeah.
That's 4 holes that's in the uterus.
Mm-hmm.
Now we routinely do it with 3 holes. So 1 scope and 2 ports to do the surgery. Um, we used to only close the back with 2 layers. Now we create a myofascial flap to bring together to create 3 layers in the baby's back, just like they do in the postnatal repair. Um, and ways to close the uterus so that the holes can be closed after we leave. That's just some of the surgical challenges that need to be overcome. So it's like a work in progress. It's
Yeah.
definitely not finished. We have a lot of work to do. And there's another condition that I am trying to move forward. It's something that has never been done in utero before. We have an application to the FDA to get it approved, and I will hope that in a year or two that we could be potentially offer fetal surgery for a completely new condition that it could potentially help those kids as well.
Yeah. Yeah. Well, the more we advance in life, the more we see that there's more to advance through, right?
Correct.
Thank you for being so patient with us, Dr. Schmidt.
Thank you, Dr.
I'm done with
Hassani,
my
for inviting me.
questions. Excuse me.
Thank you, Dr. Hassani, for inviting
Oh,
me.
yes, 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 you're very welcome. We will now take a few questions from the audience, if you don't mind. I'm sure there's several in the chat box. I'll look at them in a second, but I like to also remind everyone to please use the reactions button on the bottom of the screen to raise your hand. I will then ask you to unmute yourself and you can ask your question. Please make your questions brief so we can cover as many as possible. Let's see. You have a message from Mr. Talat Qattan. He's saying, who's responsible for slowing down the advance in your field? FDA, insurance companies, or the pharmaceutical companies?
So I would say the FDA has been very good with us.
Mhm.
Um, they are there for the safety of the patients. Of course, there are challenges and sometimes there's frustrations,
Mhm.
but to be honest with you, in the United States, we are lucky and to work under the structure that we do.
Yeah.
And I can tell you for the spine bifida surgery, the FDA delayed us for 3, 4, 5 years. But
Mhm.
was it unwarranted? No, they had legitimate issues and concerns
Mhm.
that we had to overcome. So I would say that, and nowadays in particular, where people, it's kind of um, in the press, there's been lots of negative publicity to the CDC, to the FDA. Are you kidding me? We are lucky to work in the United States with the safeguards that they provide.
Mhm.
And sometimes there's frustrations that it could be slow to get through, but they're there for a reason. And I would say that the FDA has been an ally in the sense that they're there to optimize the outcomes, but not to be obstructive, but to be there to facilitate in a safe manner. So FDA has been wonderful. Insurance companies, very difficult situation. A lot of the conditions we take care of are labeled experimental, and even though they could be life-saving for a fetus, they resist wanting to pay for these conditions. So the word obstructive could be applied to them. Pharmaceutical companies are not really connected to the work that we do, so not really for them.
Well, Muhammad, go ahead and ask your question.
Hi, thank you, Lubna, for inviting me. Dr. Chmait, I don't have a question, but I'm not a doctor. I'm a civil engineer. But the way you put things were really, really interesting, and I was really happy to be in this presentation. Thank you very much, and just keep going. You know, it's very, very interesting what you're saying, and you put it in a simple way that I understood it, even though I'm a zero in medical. So thank you very much. Thank you, Dr. Lubna, too, for this very interesting
Welcome, Muhammad. Ahlan.
Thank you.
Graziella, go ahead. Hello.
Yes, it's Jean.
Hello, Jean. Hello. Mr.
Hi,
Ambassador.
how are you? Thank you very much. It is indeed a very significant and scientific presentation. And the Lebanese in Southern California, they should be proud of you, Dr. Chmait. And thanks, Dr. Rubna, for your meaningful questions. I haven't a question, but I have a simple remark. I should say that thanks to the technology, to the advanced technology in your country, in developed country like USA, where parents are indeed so lucky. But in poor and developing countries, where medical technology is not advanced, it is indeed a disaster, since there is a high risk, since the high percentage of deaths of a newborn is very high. It is indeed a big problem. It is we live in a global humanity. What do you think about those newborns in poor countries? Thank you.
Thank you for that very important question. You'll be surprised to know that this field of fetal therapy actually is present in many so-called third world countries. In some ways, it's very interesting that our field is available for them, for patients, but the neonatal care is not so optimal. So that is the worry. Also, the prenatal evaluation, having an ultrasound in a timely fashion to identify some of these problems is also the issue too. So you will find that there could be a fetal surgery center in a third world country, but the lack is not with the technology or with the expertise. The physician is there and they can offer treatments, but the general ability to diagnose the problem and siphon the patient to that area and for the patient to have the resources to pay for it is one of the big problems. And then after the baby is born, to be able to take care of a high-risk baby. Some of our outcomes rely on the fact that after the baby is born, there's expert doctors who can take care of those children afterwards. So there's a little bit of an irony in that. There's many third world countries that actually have this technology, but it's locked up in an ivory tower, and the access is challenging. There is a doctor in AUB who understands and I think may have even done a couple cases of twin transfusion syndrome, and he trained in France. And I'm sorry, I can't recall his name. But the problem is not that he's more than capable of offering this surgery. But I think the problem in Lebanon, for example, is who's going to diagnose this in the community? Who's going to be able to understand to refer the patient to this doctor? And can that patient pay for it? So those are the challenges I think that third world countries have.
Well, we have a message from Shawqi Makarim. He's saying that you're a brilliant surgeon, Dr. Chmait, and we're all proud of you. The way you simplify in explaining your procedures to those of us non-medical individuals is very impressive and make us appreciate your work even more. Good luck and God bless you. You have a question from Ghada Rishani. She's saying, what is your advice to young people who are about to kick off their journey in the medical field? You talked a little bit about that.
I did, and I think it's very important to know, and I've told all the people who know me, I've explained this to them. You just need to be a hard worker and to be focused, and to be present, to be willing to be there and show up on time. It's so simple. You don't have to be the smartest person in the room, but you have to have a work ethic. And it's going back to your question, Dr. Hassani, about being raised by parents who understood that work ethic. And I'm hoping that I'm passing that to my kids as well. But to be able to be present so that when the door finally opens, you're there to be there. If you're not there, if the door could open and then close and you just miss it. So work hard, be the first one there, the last one to leave. Don't be lazy. I mean, it's as simple as that. And of course, surround yourself with good people. Those 5 words are very important. It's so simple, but very important, because the wrong people can drag you down. So I think it's really that simple. If you can follow that, you will succeed.
Yes. How about open-mindedness?
Yes, to be willing to ask the question. Just because something is written in a textbook, does that mean it's true? Is there other opportunities or possibilities to affect change rather than following the dogma that's already out there? And that's where young minds who ask these questions can make a big difference.
Yeah. One last question for you, I promise, from Tariq Abisab. He's saying, Dr. Chmait, do you have any specific conditions you plan on tackling next in your career?
I do. I've already alluded to it in the sense that I have an application to the FDA already, but I have not heard my response yet. And I'm hoping to get approval to offer a surgery for this condition soon.
Well, thank you. I think I will wrap it up here. Dr. Chmait, again, it's been a great pleasure.
Thank you.
You have an inspiring story. You have an inspiring story, and thank you for sharing it. Also, thanks to all of you who joined us today. Please don't forget to connect with us again. Unheard Stories will come to you monthly on the last Saturday of every month. Goodbye for now. See you next time. Bye-bye.